Hello, I'm Dan Langholtz. I'll be your guide for this program as we look at various aspects of providing counseling to deaf clients. This program is geared toward two major groups of counselors: those who have been working with deaf clients for a long time but may have limited experience working in the field of addiction or chemical use disorders, and those who may have extensive experience working with addicted people but perhaps have not yet worked with deaf individuals. This program portrays three counseling sessions with clients of varying backgrounds. The first client has language delays, while the clients in the other two scenarios are fluent signers. The first two counselors sign directly with their clients. In the first session, the counselor is deaf; in the second, hearing; in the third, a hearing counselor works with an interpreter. Most deaf people who use sign language identify as culturally deaf and maintain healthy identities as deaf persons. They are members of a minority group, akin to African Americans, Asian Americans, Hispanic Americans, and the lesbian and gay community. They too have experienced oppression, discrimination, disrespect, and significant barriers to communication. To them, deafness is not a hearing loss, but part of a healthy identity as a person who experiences the world visually. To learn more about deaf culture, see the additional resources section of this DVD. A small percentage of the general population is deaf. There are no recent or comprehensive figures on how many deaf people have a substance use disorder. Current literature suggests that substance use and abuse among people with hearing loss is at least as prevalent as that among hearing people. A compounding factor is that they face significant barriers to information. Finding effective treatment is often a difficult struggle, and they have a number of unique risk factors. Styles of communication you may see range from fluency in sign language to idiosyncratic home signs or speech. Some deaf people have delays in language development. Clinicians who sign must match language needs of each client. If working with an interpreter, you'll need to periodically check to make sure communication is clear and comfortable. Substance abuse treatment may involve new vocabulary for the client you're working with, so some expansion may be needed to ensure that these concepts are understood. Some examples are one day at a time, stinking thinking, easy does it, PPTs, that is, people, places, and things, and Friends of Bill W. Some of your clients may use their own idiosyncratic or regional signs for various drug and alcohol-related concepts. It's very important to discuss terms and agree on the signs you will use for them. There is no universal treatment approach that is effective for every deaf person. Many approaches have been used over the years. In this program, we'll review three of the more commonly used treatment models and offer some helpful background information in understanding treatment for deaf individuals. You may not subscribe specifically to any one of these orientations. Even so, a basic understanding can help you to develop skills to work with this group. These models are the disease model, also known as the Minnesota model, cognitive behavioral therapy, also known as CBT, and motivational interviewing. Again, this program is not intended to be instructive in these approaches, but rather seeks to inform the viewer. In the following scenarios, see what aspects of each approach you recognize. The disease model, or the Minnesota model, is based on the 12-step program of Alcoholics Anonymous. In this model, chemical addiction is seen as a primary, chronic, and progressive disease. It's primary because it is an entity in itself and not caused by other factors, such as intrapsychic conflict. It's chronic because a client cannot return to quote-unquote normal drinking once an addiction is established. It's progressive because symptoms and consequences continue to occur with increasing severity as use continues. The Minnesota model is characterized by a thorough and ongoing assessment of all aspects of the client and of multimodal therapeutic approaches, and may include group and individual therapy, family education and support, and other methods. Treatment settings can be inpatient or outpatient. A multidisciplinary team of professionals, including counselors, psychologists, and nurses, meet frequently to plan and assist the treatment process for each client. The assumption is that abstinence is the prerequisite. Treatment provides tools and a context for the client to learn new ways of living without alcohol and drugs. The goal is achieved by applying the principles of the 12-step philosophy, which include frequent meetings with other recovering people and changes in daily behaviors. The ultimate goal is personality change, or change in basic thinking, feeling, and acting in the world. Within the model, this change is referred to as a spiritual experience. CBT, or cognitive behavioral therapy, is simply a therapeutic approach that integrates the cognitive restructuring approach of traditional cognitive therapy and the behavior modification techniques of traditional behavioral therapy. The cognitive component of CBT is just that, cognition or thought. One of the tenets of CBT is that distorted perceptions form our emotional response. Or put another way, we get to feel what we think. CBT would have us focus on our current negative thinking patterns, distorted concepts of self, our attitudes and assumptions, limiting beliefs, and mental imagery, for example. The cognitive component of cognitive behavioral therapy is about training people to recognize negative thinking patterns. We can then focus our attention on changing these cognitive distortions and reducing the time we spend playing out these distortions. This is where the behavior part comes in. On the behavioral level, cognitive behavioral therapy focuses on changing unhealthy or unwanted behaviors that reinforce our negative thinking patterns. Behavioral strategies for coping with procrastination, dealing with anger, self-medicating with food, alcohol, or other substance abuse, for example, might be part of CBT-focused treatment, as well as social interaction and communication skills. This model emphasizes teaching relaxation techniques, the importance of moderate physical activity each day, and proper diet and nutrition in order to complement cognitive restructuring. Motivational interviewing is not a technique or a set of techniques, but rather should be considered as an interpersonal style. Motivational interviewing is a directive, client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. The approach is characterized in a few key points. First, motivation to change is elicited from the client and not imposed from without. The therapist is watchful for signs of the client's ambivalence and is ready to point these out to the client. Second, it's the client's job, not the counselor's, to articulate and resolve his or her ambivalence. The counselor's task is to facilitate expression of both sides of the ambivalence. Third, with motivational interviewing, direct persuasion is not effective and is actually believed to increase client resistance. The counselor should not assume that the client has the social skills necessary to engage in this type of therapy. Some deaf clients may have had limited modeling of these skills and may have limited or delayed language. They may be weak in areas such as problem solving, help seeking, expression of emotion, and self-advocacy. The counselor is well advised to check that the client has these skills as they move forward in their recovery. There are some recommended interaction techniques for motivational interviewing. These are most easily remembered by the acronym OARS.